formally begin our webinar, welcome to Technology for Improved Wound Management. This webinar is sponsored by Woundrounds and also by Provena Life Connections. I'd like to take this opportunity to introduce you to our primary speaker today. Our primary speaker is Beth Florczak. She is in charge of quality and clinical excellence for Provena Life Connections. Provena is a multi-site, multi-state organization across the continuum of care, and Beth will tell us more about her organization and her role there. Prior to her work at Provena, she was also at the Advocate Health System, and she will explain to us a little bit more about how she got to where she is and how she is a proponent of technology for improved wound care. A little bit about myself. I'm your moderator today. My name is Deborah Kurtz, and I work in the healthcare and the wound care space, and you can contact me at my website above. But at this time, I'd like to turn the floor over to our speaker, Beth Florczak. And Beth, who will be our primary speaker today, will talk about her experiences and her experiences at Provena Life Connections in the area of improved wound care through the use of technology. Beth, thank you for joining us today.
Deb, thank you for inviting me to participate in this webinar. It's a real pleasure to be able to share the experience of Provena Life Connections related to implementation of technology for our wound management programs, and particularly our experience with Woundrounds in adapting to that technology. As the Director of Quality and Clinical Excellence at Provena Life Connections, I've been fortunate enough to have oversight for the wound management programs for 10 of our nursing homes. And we have had a variety of experiences as we've implemented changes to keep up with clinical practice. So it'll be interesting to talk today with the audience about our experiences with that, and I think some of them will find that our experiences are not dissimilar from their own. As we begin, we're going to be talking specifically about 4 areas of how technology began to improve our wound management processes. First, we'll talk about clinical results, and in particular the reduction in facility-acquired pressure ulcers and our ability to predict and prevent pressure ulcers. We'll talk about nursing results, how we decreased nursing time and streamlined our workflow. We'll talk about the risk results. We decreased, looking at legal and regulatory risk and how those are being decreased, and how technology in our wound management program helps to reduce our overall wound care costs. A little bit about Provena Life Connections. As Deb mentioned, we do have locations throughout Illinois, Indiana, and Wisconsin. Life Connections is a part of a larger health system, Provena Health, based in the collar counties of Chicago, and we have recently merged with Resurrection Healthcare to become the largest Catholic healthcare organization in the state of Illinois. We do provide this constellation of services, so not only do we have, that you can see on your screen, not only do we offer skilled nursing services in our nursing homes, but we have that constellation surrounding the entire acute episode. As practitioners in long-term care, you're very aware that wound management can be a very complex. It's a highly variable, and particularly around the use of, I like to talk about it from the use of protocols. We often see the variability in wound management in our nursing homes based on history and what a particular practitioner has enjoyed or liked in the past. It's also very costly. If you're not using formularies for a product, it's costly in product, it's costly in the time of your staff, it's costly to your patients, and it's time consuming. We spend a lot of time documenting and providing care to our residents in order to provide the best possible care. However, it's often very disjointed. There's this lack of standardized documentation. It inhibits communication and coordination of care across settings. When we look at our residents, they often move back and forth between the acute care setting, the skilled nursing setting, and then back into the home care setting. Unfortunately, we see a complete different language used sometimes, or different documentation forms to communicate the care that's best for that resident. How are we in the nursing home providing care for prevention of wounds when we know someone's at risk, as opposed to how someone in the hospital is providing that care? And how do we communicate that information very easily to those caregivers in those variety of settings? And that variability in wound management really increase our exposure to risk. In the nursing home side, definitely our exposure to risk is increased around the regulatory experience with state surveys on a regular basis. And also increasingly we'll talk about the legal risk that we're exposed to as we move into, as we're in an economic climate and a highly litigious society. So documentation becomes of utmost importance as we look at all of those different areas. Certainly in the skilled nursing area, the support for the skilled level of service. As we see changes in reimbursement and we see changes in regulation, it's essential that we document and show that we are providing the level of service that we're indicating in our billing to whatever the payer source is. We also need to support the frequency and type of treatment. Reimbursement is based on a particular treatment modality for a particular type of wound. So it's very important that we are able to clearly support that in our documentation. We need to support our preventive interventions, and we'll talk a little bit more about that, but it's very important that we are able to show that we've done those things that are possible for our resident, identified what their risk is, and provided appropriate interventions and documented them. Then we need to support the determination of unavoidable. Now, this certainly applies very much during our survey situations, and we'll talk a little bit about that too. Particularly this avoidable versus unavoidable, as you should be able to see on your screen. And if you are, since most of you are working in a long-term care facility or in the nursing home background, avoidable pressure ulcers are those that the determination of avoidable versus unavoidable, is very important during your survey situations. An avoidable pressure ulcer is really not related to pathology. The resident has a right to refuse, or it's not related to the normal aging. Avoidable pressure ulcers, or the determination of an avoidable pressure ulcer, really exposes nursing homes to these costly survey violations and significant risks of lawsuits. And avoidable is, and we'll talk how those determinations are made and what we do to identify whether a pressure ulcer was avoidable or unavoidable. Those unavoidable pressure ulcers are those that happen even though our best efforts have been put into place to prevent that possibility. We really have to, facilities have to have a process in place that meets that criteria as outlined in the F tags, particularly F314 and the guidance to surveyors of what they should be looking for, that a facility has appropriately put into place those interventions, and that it must be documented appropriately so that it is visible to anyone who would review that medical record. Let's talk a little bit about that criteria for avoidable versus unavoidable. It's essential that, well, actually it's outlined in the F314 guidelines that each resident's condition must be evaluated for risk factors. We certainly utilize a number of tools to do that, and we like to use evidence-based tools. So we use the Braden scale to determine what the risk factors are for residents. Also, you need to define and implement the interventions consistent with the needs or goals of that resident. So it's very important that we look at what are the particular risk factors for that resident and put into place interventions that address those specific risk factors. We need to assure that care is delivered and based on recognized standards of practice. As time changes, those standards of practice change, and so it's very important that practitioners keep up on what is current as far as the care of residents at risk and those who do have pressure ulcers. You need to monitor and evaluate the impact of those interventions. Did the particular intervention work for that resident as we had intended? Do we need to make any tweaks to those? And that is that revision of interventions appropriately for that resident. So once you have all of those things in place, you may be able to then identify that this pressure ulcer is unavoidable for that resident. However, these all need to be clearly documented. Also in nursing homes, we need to be cognizant of the fact that our MDS 3.0 has changed. This is one of our documentation areas, and the MDS 3.0 changed, as many of you are aware, in October of 2010. Section M brought great changes from the Section M in MDS 2.0, and it really answered many of the challenges that practitioners had in nursing homes around explaining or showing what was happening with pressure ulcers. The present on admission piece is new, and that's absolutely fabulous to show that we have residents who already have these ulcers or wounds in place and what we're doing to make improvements. The evidence is based on the assessment of pressure ulcers, really looking at what is the current clinical practice around documentation about staging and not reverse staging wounds and identifying the current stage of a pressure ulcer. It really gives an objective measure of improvement in Section M because now it's looking at almost a modified push tool, and so we're able to show clearly that this wound is making progress. And there's also an expectation of risk assessment. One of the questions that is asked is, has the resident been evaluated using a clinical risk assessment tool? So that leads us into a little bit about the experience of Provena itself and how we looked at our wound management program through the eyes of one of our facilities. This was really a quality initiative to improve the quality of care for our residents at Provena Heritage Village. It's a 51-bed skilled nursing facility who had some challenges in their implementation of good practices around wound care. The facility had internal and external challenges. It had a less than stellar survey experience around the idea of pressure ulcers. They had some internal goals and expectations that they needed to meet. We use a lot of the data that we collect from the quality measures externally that were published on Nursing Home Compare. We use internal benchmarking around pressure ulcers and the processes of care. And so Heritage Village was really looking for a way to improve their performance in all of these areas. And so in the fall of 2008, the staff from the facility wanted to utilize technology, and Woundrounds was being that technology. So we conducted a 90-day IRB-approved study of this electronic documentation system to see if it would make an impact on improving their risk identification and the management of pressure ulcers. It would test the effectiveness of the system to get our skilled nurses to provide wound care more effectively through better data collection and increased access to the information that was available. And that approach, as I mentioned, was Woundrounds. Unlike their previous approaches, Woundrounds provided point-of-care documentation and a wound care management solution. We had a great experience with using technology already in our facilities. We had used bedside documentation by 2008 using handheld devices for our CNAs to capture their ADL information and the ongoing care of our residents. We were utilizing an electronic documentation system for the MDS and also for our nurses' notes and other assessments. This was just an adjunct to that technology that was already in place. What we liked about it was it allowed the nurses to have some control We were able to upload data and images to secure servers. This technology provided us with the opportunity to do photographs of wounds. We were unable to do that previously without quite a bit of cumbersome materials and loss of images, and then questions about did this image really match with that wound, and then we were able to print the documentation and reports and have them available to us very easily as part of the chart. When you look at today's and actually Heritage Village's process when we began this, on the slide that's in front of you, we used a very paper-driven documentation system. Our electronic health record really did not have a wound module built into it. We had been working with our other facilities and internally to develop a tool that was built into the system. However, it was very cumbersome, and when printed out, the reports were 4 pages long. With the paper-based system, we saw practitioners using scraps of paper to put wound measurements on and tucking those into their pockets and then documenting later. So you can see that sometimes those documents that maybe your experience, the documents are scattered throughout the facility and not easily organized or retrievable. Planning is sometimes haphazard. We would have pieces of the care plan in one place, and we would have documentation in another. It was difficult. It's difficult to do monitoring and reporting over time. With the new system, utilizing Woundrounds, again, we had point of care, and our nurse, with evidence-based practices built in. We had electronic visibility of the information that was put in, and we could also print it on demand and keep that as part of our ongoing medical record. The treatments were tied to the facility formulary, and as we begin to talk, as I talked about cost and formularies previously, it reduced the ability of nurses to utilize their favored treatments and to really tie to the formulary that we had established for all of our facilities. We had some reporting and monitoring. There's a dashboard that let us know how residents were doing individually, and also it gave us the push tool, which gave us a real visual on how well people were doing with healing. And then we were able to get QA reporting. Nurses in long-term care facilities can spend hours pulling together all of the information around wounds and risk levels to pull that for their QA reports. This really was able to pull all that information together with the click of a button. No other entry into spreadsheets or other tick marks on pieces of paper. And then we had and it also provided them an MDS Section M report to make completion of the MDS much more accurate and to the point. This schematic really shows the complexity of wound care management, of the wound care management process in the nursing workflow. When a resident is admitted, there are a number of things that are required to be done in a very, very short period of time, really looking at that risk assessment and putting into place prevention planning. We know that we need to identify within 24 hours of admission if there are any existing skin conditions, what we're going to do about them, what their risk is for acquiring more, and how do we communicate that information to the rest of the care staff. The wound assessment and then that care management piece is an ongoing challenge. Completion of an accurate wound assessment on a regular basis, making sure that we have a documentation system in place and that it's happening at least every 7 days in a timely fashion. What are we doing around treatments, and do we have effective treatments in place? What are those validated tools we're using to measure how a resident is doing? What kinds of dashboards do we have? How are we getting there? And then that outcomes reporting. And all of this can be very, very cumbersome, time-consuming, and difficult to do if you're doing paper tracking or have multiple caregivers who are involved in the process along the way. So it certainly was to our advantage to look at how could we streamline these, or at least put all the pieces into place so that we would have one system for getting the information that we needed. And certainly, as an organization with multiple sites, we also wanted to have that ability to look at those outcomes from a very high level. So not just at the facility level, but what was happening across that facility, and be able to monitor that from the corporate offices. So we really looked at this as, Heritage Village really looked at this as a process improvement for their wound care. It really, the whole implementation of this technology redefined their wound management process. We found there was a better allocation of resources for these high-risk patients. The system provided information on how many wounds they had and in what categories. They could see what they had. And it told their wound nurses where their energy should be spent, because it had this facility, they took a facility-wide focus on prevention to achieve these measurable reductions in pressure ulcers, and they were able to, use of the reports and the data they were capturing in this process, focus their efforts where they needed to be focused. So if residents had a particular risk category in nutrition, if nutrition was their risk, we knew that staff would not then need to focus on turning and repositioning that particular resident. It was valuable to be able to record to view these records and the photos from a distance. So really using that information to look at the resident, to look at this information for use in education of the staff, determining what focus areas might be important. If we had a lot of residents that had nutritional issues, maybe the dietary staff would be the folks that we needed to work with, who were overseeing the dining experience and encouraging residents for more protein in their diet, as opposed, and also their hydration pieces. All the team members were involved in these prevention efforts, and so they're discussed on a regular basis. We really looked at how do we get that team involved. Nursing staff were involved in prevention and management of these lower acuity wound patients, and allowed our wound care trained nurse to really focus on those residents who were challenging and identify them easily. Getting those CNAs, dietary, and other interdisciplinary team members engaged in that implementation of these preventive interventions. So how do we communicate that information? Well, being able to pull this up and pull up these reports made it very easy for these residents to be discussed during their daily Medicare meetings. So on a daily basis, we could just pull that information very quickly and review with other team members who might be interacting with residents that day. So how did all of this come together, and what were those outcomes? Well, in a 6-month, you see 6 months of data on your screen now, and the facility was able to decrease their pressure ulcers, their facility-acquired pressure ulcers, in that 180 days. By 80%. So you can see where they began in November of 2008, and by the time they finished this data collection period in April, their facility acquireds, identified by that red line on your graph, was sustained at a very, very low level. Now, they did not have 0 facility-acquired pressure ulcers, but they were very close to that. Certainly one measure of implementation of any kind of new process is, are you able to sustain that? So when you have something that's new and novel, and we've got a lot of focus on it, particularly because we were doing this as a quality improvement project with an IRB, with a report to go back to those stakeholders, there was a level of commitment in that first 6 months. But how were they able to sustain that over time? Well, if you look at this consistent and sustained results, their total pressure ulcers per month across that almost 13 months. So if you look at November of 2008 through December of 2009, the facility was really reduced those numbers of facility-acquired pressure ulcers through using that technology, having better access to information, and they showed that they had less than 5 facility-acquired pressure ulcers per month, and no fines or citations, because within that period of time, they also had undergone their state survey for licensure during that time. Well, it's great that we'll be able to look at this as from the big picture and seeing the results as a roll-up, but in nursing, we know that it really comes down to the patient. And how can we apply this to individual patients? I'd really like to show you 2 case studies that highlight what this improvement in the process was able to do for this facility and how the facility really felt that this made a significant impact in the care that they were able to deliver. The first case they label as against all odds, and as you can see, this is on your screen. This is a 78-year-old patient who was admitted to the facility. He had multiple medical problems, and prior to coming to the facility, he had this extremely complicated history. He was going to undergo surgery. The patient fell prior to having a procedure. He was admitted to the hospital, and he had this left acetabular fracture. They discharged him to Heritage Village to continue his recovery, particularly with a rehab focus. On his initial assessment, it showed that he had multiple medical problems. We saw that from his history. And he also had a stage 4 pressure ulcer to his left Achilles with exposed tendons. Well, with the technology that we had available to us during this pilot study, we were able to easily monitor this wound healing. The facility put in place a plan to address the risk factors, to address the wound itself, and as you can see from these photographs, you can see the progress and the response to the treatment plan. The photos really provided an illustration of the progress that written documentation alone can't capture. We could have measurements, we could have explained the stages, we could have explained the tissue type, but I think the photographs really give a clear illustration of the progress that this wound was able to make. Secondly, that web-based technology really allowed the physician and other consultants to take a look and be involved in the progress of this wound from a distance. So we're able to give physician access to the technology through a password, and they could see the information and see the photographs of the wound and make changes based on the appearance of the wound if necessary. The documentation itself was very, very valuable. The photos certainly illustrate great changes and great progress. But by documenting at the bedside, our nurse can capture all the vital information as it's seen and can easily take that photo and then it's embedded right with the documentation so the two are not separated from each other. I talked at the beginning about the challenge that we had with photographs and documentation and them not always matching with each other. So this really was able to eliminate that problem. And we know that all the information is captured that's necessary because the system would not allow the wound nurse to move forward without addressing any of the key areas of documentation. That standardized language of documentation that meets the clinical practice guidelines, it really made it made certain that we were capturing everything that was needed. We were able to see trends, and the data is there, the assessment details, and any notes about the resident. So what is the general tenor of what was happening as far as this case was concerned. Other reports that were available also really provided that opportunity for monitoring of the wound. This is one of the graphs that was available and one of the ways that we can easily monitor wound healing. So for this particular resident, you can see the dramatic improvements in his push score, and that is the upper of the two graphs. The second graph, or the lower one on the screen, shows the progress toward healing also, but without looking at the total push score, we're able to see just the improvement in the measure of the wound itself. So it really it really gave a visual of how well this wound is doing. And our protocols were based at the time and still are on the standard of practice that if we weren't seeing improvement within 2 weeks, an objective measure of improvement, we really needed to relook at that treatment plan. We were also able to monitor the risk trends. So by doing a Braden score, we were able to see how this resident was doing over time. We can easily look at weekly reports, and it clearly shows, looking at this report for our case 1 patient, that his particular problem was due to being chair fast. So because we knew that his had limited activity. He was in his chair most of the time. We're able to focus our efforts on making sure we reduced pressure. Did we have a cushion in the chair? Were we doing those things that were most important for that resident and his risk levels to prevent any further breakdown in his skin condition? So this shows the successful outcome for this patient. He was able to return home after 2.5 months with minimal scarring, and the resident's family and he himself were extremely pleased with the progress. They were able to meet his goal of healing, and he got to go home, and they prevented any further breakdown while the resident was here. So using the information that they had available to them through risk assessment, trend reporting, they were able to really make an impact for this resident, and what could be more successful than that? A second case also illustrates the significance of using technology to guide our care decisions. This is an 84-year-old male patient who came to the facility following an accident. As you can see from before the car accident that prompted his admission to the facility, he had been very independent. He did have some medical issues, but not significant. And he did have these 2 small blisters on his right foot. And that's going to be very important to this case. After the accident, we see that there was a dramatic decline in the resident. He had functional declines. He had generalized weakness, dementia, gait and mobility. So he was at much greater risk. So following this accident, he was admitted to our SNF. It came as a status post-CVA, so that matches up with a little bit with what we saw as many of his problems there. His goals were really about rehabilitation and strengthening and therapy, but he did come in complaining of pain to the foot on his admission. And the admission report from the hospital said that the patient had blisters. Well, as you can see from the illustrations taken on admission, he had not just blisters, he had 3 open wounds at the time of admission. So that leads us to that really understanding that care across the continuum and how technology can make a difference in our documentation and how we communicate that information. So we began to document around this resident's case as we did in case 1, and the ease of assessment at the bedside really made care go smoothly. It made documentation go smoothly, and it made the care go much more smoothly. We were able to capture all of the wound assessment details and have clear photographs of the progress that this wound was making. As you can see from these graphs, he showed marked and continued improvement over time. This is the wound on his right heel, which you just saw. We were also able to really look at his risks. What was happening with this resident's risks? Because we had been doing a Braden score, you can see that his risk profile really identified poor nutrition as his focus. So we were able to implement interventions that focused on improving his nutritional status to promote healing and to prevent further breakdown. The last point on the graph, though, you see that he has a spike in his Braden score, and as you know, the lower the score, the higher the risk for the resident. What they found was that his incontinence had increased, and they were able to track very closely through their bowel and bladder records that the resident had indeed developed a UTI. By catching this early, they were able to intervene for this UTI, and then you can see that they were able to address it and reduce his risk factors from that point. After the UTI was identified, the treatment plan was changed, the patient improved, his appetite improved also, and he progressed to his goal of returning home. The resident saw remarkable results with physical therapy. By the time he was discharged, he was performing all his ADLs independently. Speech cleared him, occupational therapy cleared him, and he progressed. He was able to go home after 2 months, and as you can see, those wounds very, very well healed at that time. One of the other items that we really looked at as we implemented this technology were the nursing results. So it's great that we had great clinical results, but nurses are those who have to provide the care at the bedside. What kinds of things were we looking for? We were looking for that decreased nursing time and a streamlined workflow. So we had to do some comparisons. How would we know that this change was actually an improvement? We can put in a lot of changes in quality improvement. It doesn't necessarily mean that it's making a difference or making anything any better. So we looked at automated charting and reporting as creating a time savings. The nurse at the time who was involved in this pilot project estimated that she was saving 8 to 10 hours a week for this wound care nurse. That really factors into some substantial amounts of saving, not just with her time, but also with satisfaction. If you think of a nurse who has multiple hats in a long-term care facility, and in our case, that was our ADON. This was time that was freed up to work with staff, to do education, to handle many of those other responsibilities that she had. Our staff nurse satisfaction increased because they were really able to see that these reports increase the performance, the ease of performing their job. So they were able to easily retrieve information. They had better communication with physicians because everything was in one place. They weren't searching for it. They were assured that documentation was done timely, and they were using the same language as they communicated to each other and to the physicians. So our staff nurses were really felt more comfortable with the assessments that they were making, the interventions, and the need to change interventions. So improving staff satisfaction was very important. Risk results was the next area that we really looked at. How was improvement in our documentation going to decrease our legal and regulatory risk? Well, at the time, and still existing, we know that there's been a changing regulatory landscape. We really see increasingly that there is a focus on a punitive approach to surveyors within our facilities. We also are seeing a lot of other changes in regulation around healthcare reform, value-based purchasing, the focus on these accountable care organizations. So our economic situation also seems to encourage fines and citations. We're seeing ongoing increases in complaint surveys. We're seeing a focus on attorneys in many of our areas encouraging families who they're working with to have a citation associated with a pressure ulcer or some other care delivery process. And at Provena, our situation was that we had certainly internal quality goals and benchmarks. Our facilities are benchmarked against themselves, against others, against national databases. We saw external pressure from the quality measures and what was happening with the facility itself. Heritage Village had because they're a very small facility and had a number of pressure ulcers, whether they were facility acquired or they were admitted from the community, their quality measures were not favorable in comparison to other like-sized facilities in the area. And they had this burning desire for improvement. We really have a focus on continuous quality improvement using PDSA models and really working from a quality perspective within the organization. One of our nursing homes had actually worked with the National Nursing Home Improvement Collaborative earlier in 2005, and out of that, the studies from across the country came a publication that showed that if the effectiveness of pressure ulcer prevention, as you can see, and treatment is the only way nursing homes can hope to defend against legal and regulatory liability associated with poor pressure ulcer outcomes. So really understanding what was going on and reducing the risk for residents and reducing our risks and liabilities was an important component of this. So what happened within? So the significant improvement in our risk profile occurred within those 6 months. As we talked about with Heritage Village, we had less than 5 facility-acquired pressure ulcers per month. We had no fines or citations, and because they had undergone their state survey, they were very favorable state surveys during that period of time. We had surveyors in the state of Illinois who had come in for a visit and actually complimented the staff on their ability to provide the information that they were requesting in a timely fashion. They were very impressed with the changes that they had seen from the previous survey, which was not as favorable to the facility. So it really made a significant impact for that facility in the experience with surveyors. And finally, we looked at the improvement from a cost perspective. How could this technology implementation really assist in reducing wound care costs? And when we look at wound care costs, we looked at costs in a number of ways. We're going to look at, first, we looked at return on investment. So certainly fewer wounds led to less spending on wound care. To extrapolate out some costs, if you look at based on a treatment cost per wound per day per stage, you can see that for stage 1 you may, some literature suggests that $24 a day would be spent on wound care. And certainly that's not just dressings. Stage 1, that's staff time, that's efforts, that's turning, positioning, putting into place all of those interventions. To the cost for a stage 4 of perhaps up to $175 a day. So when we utilize that, look at that information, an estimated annual cost of care was reduced at Heritage Village from greater than $110,000 to less than $35,000. In that time period. And that's really based on fall of 2008. The facility had they were treating greater than 70 pressure ulcers in a month. And up to one-fourth to one-third of those were facility-acquired pressure ulcers. So not only did we have difficulties with those costs, you're looking at the cost of goodwill for residents who are developing a pressure ulcer within your facility. We also, in 2010, with a big focus now on changes in healthcare reimbursement and how we position ourselves to be a facility of choice as residents are discharged from the hospital and returning and looking at value-based purchasing, we implemented a focus on reducing our re-hospitalization rate. So we were able to look at some data around 2010 re-hospitalizations and how that impacts our revenues. So Heritage, when we looked at data across all of our facilities, we found that the rate of rehospitalization for all residents at Provena Heritage Village was a best practice within our organization. So their rate of rehospitalization was 20%. The rate of rehospitalization for residents with stage 3 or 4 pressure ulcers was 32%, and a best practice at Heritage Village was 35%. The rate of rehospitalization for more severe wounds was even greater. All facilities are 43%, and the best practice of Heritage Village is at 17%. Really, rehospitalization costs are not just associated with the cost of care, and the cost, it impacts the reputation of the facility in the community, and it impacts our relationships with physicians and hospitals. If we're rehospitalizing residents on a regular basis, we're reducing the time, we're reducing our reimbursement rate from having residents in that bed at that time, but also it's impacting the potential of them not coming back to our facility once they've returned to the hospital. Here's another way really to look at the effect or the impact of reducing rehospitalizations. If we were able to reduce from 26%, which is the average, to make that change of 6%, which was the best practice. If we look at it from both a revenue, if we look at it from a revenue side, the potential savings, by retaining residents per 100 beds, you're looking at an estimate of about 24 residents. If you figure that the average revenue for a skilled bed is about $400 a day and a non-skilled bed is $150 a day, we're looking at a $250 a day per bed difference. So if we have a loss of 10 days per re-hospitalized patient, and we multiply that and factor it out across those 24 patients at $250 a day, the potential in revenue is $60,000. So certainly there's a potential to drive our best practices across all of our facilities. If we improve our resident retention through re-hospitalization, we also reduce our costs through the reduction of pressure ulcer volume and the costs of care. And that's really illustrated in these two slides. As you can see, we have a reduction in work that's associated with caring for residents with pressure ulcers. We still have the efforts that go into the work of identifying residents who are at risk and preventing pressure ulcers for those residents. But we have been able with this technology to really focus that work in a very direct way, as opposed to a shotgun approach of the same interventions for all residents. So we're able to have some work reductions around those. And then the revenue increases by really proactively managing those residents that have pressure ulcers. We're able to reduce the time that, we're hopefully reducing those re-hospitalizations and keeping those residents in our occupied beds for a longer period of time. We like to say without any mission, we are a mission-driven organization, and certainly there's the balance between mission and margin that must occur. But if we don't have a margin, we don't have a mission either. So it's essential that in today's climate that we really focus on both of those areas, and that was very important to us as we looked for those improvements. So overall, what were our findings on using wound care IT technology? Well, overall, clinically, we improved the monitoring and tracking of our wound status over time, and that certainly improved our quality from a measurable perspective. We saw improvements in the quality measures for the facility. We saw reductions in facility-acquired pressure ulcers. We saw this consistent, accurate documentation that was really based on these clinically validated tools and methods. We knew that push scores were being done on residents on a regular basis. We knew that our residents were having a risk tool and their specific risks identified and interventions that were appropriate for their level of risk and their types of risk. Digital imaging really allowed that visual monitoring of wounds. We're able to monitor them from long distance. So if the practitioner at the bedside ran into problems, had questions or concerns, this really allowed her to contact someone outside of the facility to get some feedback or consultations. That was huge from a clinical component. The nursing time and workflow improved. We saw that automated charting and reporting really saved time. We saw definite improvements for our staff in their satisfaction, and that data was accessible anywhere, anytime, improved that communication and collaboration. Physicians from their offices were able to make changes by logging into the system and accessing information about how well their resident was improving or not improving. From a risk perspective, that complete and accurate documentation, really, we saw it as minimizing our risk. There is a substantial risk associated with lack of documentation or inaccurate documentation or inconsistent documentation. And because we had the prompts that were available to us in this system, we knew that any nurse who was documenting were covering all of the important and essential elements associated with documentation around risk and existing wounds. And again, finally, our financial return on investment. We saw lowered wound care costs. We were really able to see that revenues increased and so did reimbursement because we were capturing the appropriate information on a timely basis. We were able to support the level of service that was being provided for our residents, not only from a wound care treatment perspective, but also from a prevention perspective. We were able to, from that, to control our costs in our use of product also. We were certain that formulary products were being used and utilized, and those reports allowed us to see what we were using for a particular wound and that they were being used and treated appropriately. Just some closing thoughts as we finish out our time together. Improving wound care really is a quality initiative. This isn't just information technology. It was very important to us that we saw this as something that happened because we wanted to make an improvement for the facility overall. The technology itself wasn't what did it. It was a focus by our leaders and our staff in making it a real difference in the lives of our residents. It really takes, secondly, it takes that leadership to change behavior and then the persistence to change the culture. We were very fortunate to have very dedicated nurses and a dedicated administrator and dedicated leaders at the facility. But those who took ownership for this entire process and making improvements were really persistent with the staff through education, through using the data, telling the story at the facility level, at the patient level, and then to a wider arena of how they were able to make a significant difference. The technology was certainly helpful to this because it gave them the time to be able to do those other things. And it can certainly transform the way we do our work, and it enables continuous improvement in cost and quality outcomes. Technology allowed us to tell our story because we had a great story to tell. Technology was a tool that we utilized and incorporated with the knowledge that we had and the great care that was being given to those residents. So it really made a significant difference at our facility. Enough so that we've implemented this technology and this technology in a number of our other facilities also. And we're seeing many of these same improvements.
Beth, I want to thank you today for explaining to us the journey that Provena Heritage Village undertook and this multidisciplinary and cross-functional effort to really make Provena a wound care-centric organization. As you can see, this took a lot of heavy lifting, and we're just thrilled to have Beth present to us today about the journey they took. At this time, while we're getting ready to open it up for questions, what we'd like to do is get a poll from you all as to how you and your facilities use technology in the wound management process. And as you're quickly polling here now, we'll be taking a look at our questions and then be turning this over to see to ask Beth some questions from the floor. So please take this opportunity to share with us how you're using your wound management and technology, and we'll close the poll in just a moment. Great. It looks like most of you have polled, so we will go ahead and share this information now. So as you can see, there's a wide margin of our audience members today that are not using technology, and hope that this will be inspirational to you as you lead your organizations through change. What we'd like to do now is turn the floor over to Beth, and as we open the floor up for questions. A moment, though, to give a big thanks to our sponsors. Beth's organization, Provena Life Connections, was a sponsor of today's webinar, so thanks to them for bringing this information to us. We're also, as you can see here, posting Beth's contact information for those of you who might want to contact her offline. Additionally, recorded copies of this webinar, including the audio and visual, will be made available to all of the participants on today's call. A big thanks also to our sponsor, Woundrounds. Woundrounds is the technology that was behind Provena's successful pilot and ongoing implementation as they became a wound management-centric organization. And Woundrounds helps nurses do more with less. The contact information for Woundrounds, as you can see, is at the bottom of this slide. So what I'd like to do right now is turn the floor back over to Beth and to you as audience members with questions. And I do notice that one question has come in for Beth about the adoption rate of the nurses with the technology. And this attendee is particularly concerned about how nurses dealt with the technology change. Wonder if you might want to speak to that, Beth.
You know, I think, Deb, that's a great question. We were very fortunate that our nurses, we're a very technology-driven organization, and we already had put into place the EHR. Our nurses are used to using a lot of devices that look very similar to the device we use with Woundrounds. If you take a look around, our staff have smartphones that they're carrying all the time. We had, as I mentioned at the beginning, we were using handheld devices for our CNAs, and we had invested an awful lot of time and effort into getting our staff comfortable with technology. When we initially implemented computer-based documentation, we spent the time to train staff to use a mouse, brought them in for centralized and both decentralized training. So they were very, it was not a huge hurdle to overcome. I think that we, as leaders, sometimes are more frightened of technology than our frontline staff members are. And they really adapt much more quickly than we do. If you look at who are some of these bedside caregivers, they do say that nurses are, the average nurse is 50 years old right now. Well, I'm in that age category myself, and I have a smartphone. It took me a little bit longer than it did my teenage son to adjust to it, but I think we cut short our, we don't give our staff enough credit if we think that they're not going to adapt easily to the technology.
Thank you, Beth. Another question has come in from the floor regarding whether or not this initiative and this software were specific only to pressure ulcers, or did this involve other types of wounds such as excoriation and burns? I wonder if you can speak to that, Beth.
Yes, actually, we do have the ability to document all of those wounds, and one of the things that we found as we implemented this in other facilities is we were capturing too much documentation in Woundrounds. It's a great system. It's able to capture the surgical sites. It captures venous ulcers, arterial ulcers, so not just pressure ulcers. And it gives us that language and ongoing standard to make comparisons. However, if you're going to utilize a technology like this to capture every bruise and every scrape and every skin tear, then you really need to make sure it gets decentralized to your staff. We have found in our experiences that capturing that type of information with just your wound nurse exclusively is not a good use of her time. So it's a great way to monitor it ongoing and to get reports, because you certainly get those roll-ups, but it's really those are the types of things that need to be decentralized to the bedside nurse also.
Thank you, Beth. Another question has come in as to whether or not you're using this technology and this initiative across all the facilities in the Provena system or exclusively in the long-term care setting. Could you speak to that?
We're really only using this in the long-term care setting at the moment. Our system is set up such that we make independent decisions by entity. So Provena Life Connections itself is under one umbrella, and Provena Health, which is primarily our hospital side, has not at this point adopted this technology. They use a different health record than we do to begin with. We use one that's specifically developed for the long-term care industry, and they use a much more acute care-driven documentation system.
So I wanted to give a big thanks to our speaker today, Beth Florczak, and also to our sponsors, Provena, and also to Woundrounds. I'm sorry that we've run out of time, but we'll try to get to other questions offline. Remember that we will be sending to all registered attendees a copy of this recorded webinar and also be sending you information about how to contact ourselves and Beth should there be any other questions. With that, I'll sign off today. I'm Deborah Kurtz, your moderator, thanking Beth Florczak, Provena, and Woundrounds for making today's webinar happen. Thanks much.